Hello everyone, welcome you all in our YouTube channel Learning Radiology. Let's start our today's topic. So today we will discuss on the topic nephrostomy or ureteric stenting. So in nephrostomy or ureteric stenting, we will learn in this topic like indication, what is the definition, and introduction about nephrostomy or ureteric stenting, an indication or a contraindication, a patient preparation, or what are the patient preparation, what is the technique, what are the procedure, what are the complication, and what are the aftercare for this procedure. So step by step we will look on each topic, each point. So nephrostomy or ureteric stenting is a procedure to drain an obstructive kidney or ureter, and also used to remove stones or infuse drug for a therapeutic reason. Means for therapeutic reasons, there are many types of disease. In therapeutic cases, we remove stones or infuse drugs in this procedure. All this is anatomy. In this image are like kidney. This is a kidney image. This is a renal pyramid. This is a papilla. This and these things are renal sinus. This is a major calyx. These are renal pelvis. These are renal vein, renal artery. These are ureter, renal capsule. These are the minor calyx and these are major calyx. These are major and these are the minor calyx. So this is a basic anatomy. And after nephrostomy, what is nephrostomy? Indications. Look over indication. So in case of obstructive uropathic disease, we go for a nephrostomy. Pyonephrosis condition, when a patient have a condition of pyonephrosis, then we do nephrostomy. Acute hydronephrosis, in acute hydronephrosis condition, we do nephrostomy for a patient. Nephrostomy procedure. This is the image of hydronephrosis patient. Prior to any percutaneous nephrolithotomy procedure or a ureteric fistula, any type of suspected ureteric fistula, external drainage may also allow closure. In case of contraindications, any type of uncontrolled bleeding or diathesis, we don't do this procedure. And contrast media for a nephrostomy procedure, we use high smaller or low smaller contrast media for outline the pelvic calical system or a renal cyst via direct into the collecting system, and for indirect opacification of pelvic calical system by intravenous injection, we use low smaller contrast media, which is 370 to 370 milligram iodine per ml, and its amount is 50 ml. We use equipment for a procedure like puncture needle, which are a coaxial needle, seated 18 gauge, a drainage catheter, which are at least 7 French pigtail catheter with multiple side holes. The guide wire is a conventional angiography, and it's a stiff wire. For a guidance, we use ultrasound machine or a fluoroscopy machine. For a patient preparation, we take history from the patient, collect previous history from the patient, we ask patient for a previous report, then we provide the hospital gown to change up their gown. Then after patient have 4-hour fasting, we provide pre-medication to the patient, prophylactic antibiotics are used, surgical backup in view of clinical workup, possible complication and further management. Means these are like we use we take previous clinical history for a further management. The antipylogram, it is used for a opacification of anterior and posterior oriented calyx. Then preferential filling of the anteriorly directed calyx with a contrast material. These images show these things. Then technique, patient should be in the supine position, patient lying prone oblique with a foam pad or a pillow under the abdomen to present the kidney optimally. These are our patient condition. Patient in a prone position, prone oblique position with a foam pad or a pillow under the abdomen. Look here. Then systematic anatomy of the percutaneous puncture. We puncture the percutaneous, use the percutaneous puncture in lateral position. We see this. Then there are two type of site selection. First one is simple urinary drainage and other one is potential ureteral negotiation. In case of simple urinary drainage, a lower pole posterior calyx assessed via subcostal approach is usually best, and in case of potential ureteral negotiation, posterior calyx of the upper or middle collecting system offer the easiest access to the uretropelvic junction. And uncomplicated stone disease is a puncture behind a stone may be the most expedient. In case of complex stone, puncture of a posterior calyx in a upper pole. In case of patient have a complex stone, then we puncture a posterior calyx in the upper pole. In case of complicated stone, we puncture a behind the stone may be most expedient. Plane of a puncture are like a plane of a puncture. It is a point on a posterior axillary line. Is also chosen below the 12th rib, having identified the mid-lower pole calyx with ultrasound or a contrast. The plane of puncture is determined, and this will via the soft tissue and the renal parenchyma, avoiding direct puncture of the renal pelvis, so that vessels around the renal pelvis will be avoided and the drainage catheter will gain some passage on the renal parenchyma. So there is a relatively avascular plane between ventral and a dorsal part of the kidney, which also afford to the ideal access. Technique of a puncture or a catheterization in the skin and the soft tissue are infiltrated with local anesthesia using spinal needle. Puncture may then be made using one of the following system like Slinger technique for catheterization, coaxial puncture system, and a trocar technique. In case of Slinger technique, we use Slinger technique for a catheterization, and we use coaxial needle puncture system using a 20 or a 22 gauge puncturing needle. That's take a special 0.018 centimeter guide wire. For a trocar technique, and the cannula system in which direct puncture of the collecting system is made with the drainage catheter already assembled over the trocar. And the trocar is introduced to facilitate the passage of the catheter in the collecting system. When the catheter is in place in the trocar, can be removed and the catheter can be put into the shape necessary to anchor it in the kidney. This will cause catheter to become larger than the pathway used to insert it, thereby anchoring it firmly in the renal collecting system. Two types of locking catheter are available. Like first one is pigtail and other one is Malicot catheter. Pigtail catheter also form a loop that locks in the kidney after the placement. In case of Malicot catheter, it plays by making the distal end larger than the insertion path. And a catheter can be anchored externally either through the use of a ostomy device or simply attaching it directly to the patient's skin. An external drainage should be continued until the decompression is achieved. This is the images. First image shows the needle inserted to the kidney. Second is guide wire passed through the needle. Third one is needle removed and the guide wire in the kidney. Fourth one is a catheter placed over the guide wire, and fifth one is the catheter in a position. These are the images, and adding a cannula needle used. You can see the picture. In case of complication in this procedure like infection, catheter dislodgement, catheter obstruction, hemorrhage, these are the indications. Complications. In case of percutaneous calculi removal, means renal calculi can be removed percutaneously from the renal pelvis, calyx or ureter using the procedure described for the percutaneous catheter nephrostomy. These are the percutaneous nephrolithotomy. Aftercare like a frequent vital sign. We use and we collect a vital sign frequently, and we use narcotics and admitted overnight to the patient in a department after initial nephrostomy. and a carefully charting of the nephrostomy tube output to access the adequacy of the drainage. These are the stenting to the bladder, to the kidney. The indications are like obstructed uropathy, pelvic ureteric obstruction, urolithotomy, leak due to the ureteral fistula, narrowing of the ureter, and any type of obstruction. Ureteric stenting. In case of ureteric stenting, it's a thin flexible tube threaded into the ureter to help urine drain from the kidney to the bladder. This is the images also seen on screen, made up of flexible metal plastic material, and a J-shaped stent and a double J stent or a pigtail stent are used, which length are about of 24 to 30 centimeter. Top end coils are used for kidney and lower end coil for inside the bladder. Inside the bladder, lower end coil are present. Inside the kidney, top end coil are present. Ureteric stenting placement. In case of ureteric stent placement in procedure, we use ureteric stenting placement is often possible for a antegrade approach. After initially entry of the guide wire is manipulated down the catheter. Once the obstructed segment has been transferred, the wire catheter combination is coiled within the bladder. When the ureteral passage is not possible at the time of initial nephrostomy entry, it may be successful after 5 to 7 days of the external drainage. And the appropriate stent length is determined by using the bent guide wire technique. These are the bent guide wire technique procedure image. These are the images for ureteric stenting. Post procedural care are like beneficial to leave nephrostomy tube in a place 24 hours. After stent placement and external drainage continued for the first 12 hours, the nephrostomy tube should be removed with fluoroscopy assistant. There are complications for ureteric stenting like transient hematuria, which are occur in virtually every patient, renal intravenous fistula, pseudoaneurysm or a vessel laceration. These are the complications. Thank you. Like the video, subscribe the channel, share the video. Thank you. We will meet in the next video. Okay, bye bye.